It's so nice to, I can talk. It's so nice to see you.
Nice to see you as well.
I've been following you, now, like not in a weird way, but I joined TikTok, I think in 2020 and found you really soon. So I've been following you all along the way. And I remember you saying your daughters encouraged you to go on. And can you just take me back a little bit to where you were then and where you are now?
So it was during the pandemic and we were all at home. The kids had one in high school and one who was in college, university. And so she had to come home, of course. And, like all families who were quarantined, we were coming up with fun things to do and games and watching, lots of TV. And I had been growing on social media with the Galveston diet and just talking about menopause on Facebook was kind of my biggest network, a little bit on Instagram. And the kids were like, Mom, you've got to do this TikTok thing. And if I'd heard of it, and, so I go on and everyone's dancing and pointing at things. And I was like, guys, this really isn't my jam. People who listen to me are my age. And they're like, no, Mom, there's other doctors on here. You should try it. And so I made a quick video, just an informational to cute music. And I was pointing at facts. And it got like 20,000 views, my very first video. And I was like, whoa, and so I like a little bit of, adrenaline chasing, dopamine chasing. I kept making more videos and they kept exploding. So I kind of grew really quickly on TikTok. It became, and it remains my biggest platform. And as what began for me was a focus on nutrition and menopause really expanded into just an all menopause discussion because I'm paying attention to the questions people are asking and I'm trying to get them answers. And it really kind of opened the door for me to realize gaps in my own education that, I don't know what other people are telling, other physicians or healthcare providers are telling patients behind closed doors. We don't come out and talk about that stuff. We talk about our kids and groceries and the usual things. And it just made me aware that at least in the United States and now worldwide, because our followers are everywhere, there is a massive amount of misinformation, of lack of education. I think healthcare providers are doing their best, but this is a societal and a systemic problem around the subject of menopause. And so I've decided to use my voice, my platforms to just spread awareness and knowledge so that women feel more empowered and can make better healthcare decisions for themselves.
And you talked about your own gaps in information. I've interviewed quite a few people now who are the experts in the field, and I'm amazed at their gaps in information. Like, and I'm just kind of sitting there as a journalist saying, that's weird. Like that person doesn't seem to know this thing. Of course, that's going to happen professionally, right? It's impossible.
Right. You cannot know everything and you can't read every study and you can't, I would have told you that I was a great menopause provider when I graduated from all my education and training programs. I knew everything they taught me. Okay. I was the woman, sorry, I still think I'm a girl.
I know.
I was the woman who aced all my exams, blew the top off of the boards, I was, and I wanted to do well by my patients, but I kind of quickly realized, I was so young. I was barely 30, when I started this journey. I was 26 when I started medical school. So do the math. And I felt like a deer in the headlights when women would just talk about menopause and talk about sexual dysfunction. And I mean, these are things that were not covered in great detail in my training program. We spent the majority of our time on obstetrics, really important stuff. I had to learn how to do surgery and gynecology, woman exams, pediatrics, oncology, fertility, and menopause just got shoved into this tiny little corner. And so it's not really the healthcare provider's fault. I think it is the fault of the education system. And those of us who are considered to be experts in the field have taken it upon ourselves to read outside of what is required so that we can be the best menopause providers to our patients. And in the US, with the healthcare system, the way it's set up, it just doesn't pay very well with insurance to focus on menopause care because we get paid to deliver babies and do procedures. That's where you make your money in OB-GYN. And so when I opened my menopause clinic, I made the difficult decision to not use the insurance model, to go with a fee-for-service model so that I would not be beholden to insurance companies telling me what I could and couldn't do for my patients.
That's kind of a tricky a thing that's emerging is this sort of two-tier level of care for menopause. Like if you have money, it seems like you can get better menopause care. But you're
I think
saying
it's
I had,
any
yeah, it's
any
any, you're
condition
absolutely
now.
right. Yeah. So, but you're saying like I sort of had to, because otherwise I wouldn't be financially
I would not
advantageous.
be able to financially take care of the people I wanted to take care of.
Right. So
There's
that's the
no
way that,
way.
okay. And
Yeah, to run insurance claims, you need 7 people in your back office. It's not easy. And so that not having to, go through the insurance rigmarole and wait for payments and fight on every little thing. I just like, here's what it costs. We're going to cover your labs. You get 2 visits, you get a nutrition program, you get exercise. I mean, I have a background in nutrition. I can do this. And I mean, my patients are really, really happy, but it is a little bit elitist, and that it's not for everyone, and I don't know how to reconcile that with the system is broken.
yeah, and it's not just the US that's happening. This is happening in many countries around the world, and it's happening in African countries, and it's happening in the Philippines too, here in the UAE where I am. Like this is just the way it's going. It's heartbreaking, but also like when you actually dig in, like it's so easy from the outside to say, oh, you're just running a chain of private clinics and making a ton of money, because that's what everyone thinks, right? But you're
Right,
saying like you
right.
just to hear the reality, like 7 people, insurance fighting, everyone's had to fight for an insurance claim. Imagine doing that on a completely daily basis. Yeah. Yeah. You wouldn't be able
Yeah,
to have that.
so it is, and then finding someone who's willing to kind of go there and do the extra reading and the research so that you can stay up with what is the latest information and research. A lot of people stop learning when they leave their training programs. And when you're board certified, at least in my specialty in OBGYN, the American board requires you to be recertified every year. And then you read like 30 articles and you answer questions about them to make sure you understood them. And it's usually groundbreaking new stuff to make, or like they've kind of revamped a guideline. And there's almost never anything to do with menopause. The first time I saw a menopause article in like 8 years was last year. And it was the one from Circulation Magazine from the American Heart Association that went and looked at the WHI data. And it was groundbreaking. I almost jumped off the treadmill because I do a lot of work. I work on my treadmill. And so I was like, oh, and so that was one they could not ignore. And not to say that the stuff they present to us is not important. If you're still doing basic OBGYN, it's important you learn new surgical techniques, keep up with what's going on in obstetrics. But menopause just, again, gets shoved in this little corner. And it's just not brought to the forefront. 1/3 of women in the world are somewhere in their menopausal journey. And yet, there's societal problems and education problems around how we help them and treat them.
And you pointed out in a TikTok video something I thought was brilliant, which was look on PubMed for the number of pregnancy studies, almost 1 million. Look for menopause. It was like 92,000 when you pointed that out.
Yeah. So
That,
at that time it was 1.1 million. You just type in the word pregnancy.
oh, 1.1. Okay.
The database pulls up every article with the word pregnancy in it. 1.1 million from all time. Okay. And then for menopause, it was 94,000. So yeah, pretty close. And I was like, okay, well, what about the last 10 years? So of course, 100 years ago, 50 years ago, menopause. Okay. But what about just the last 10 years? Exactly the same 10% ratio held.
So even
So that's 10% of the brain power, 10%
yeah.
of the money, 10% of the research funding. I mean, when you look at how research is done, bench research, it is a financial and political rigmarole to get anything done. I've developed 1,000 studies in my head, but to get these things funded, it is so expensive. It is so, the hurdles you have to jump over are almost insurmountable. Yeah. And so people make a lifetime career. There are careers around helping people get grants to do studies because it's so difficult.
And with that small amount of, I mean, what scares me is when people speak so authoritatively on on basically such a small amount of research, right? Like it's such a developing story. I can't wait till I'm 80 and see what they're coming up with from menopause. But how do you reconcile that? Because you're talking about a body of research that's very small comparative to other situations.
It's all we have. Yeah. And so that is what we have to go with. But the good news is the stuff that is coming out in the last 2 years, we've got this explosion of conversation going on right now in social media and Oprah and digital formats, everyone there's the Gold Rush, the New York Times, People are talking, and that is going to lead to funding. Now, what's happening is there's a lot of savvy entrepreneurs who are seeing the pain points, realizing we have a gap in care, and they're developing telemedicine companies. Every time I open up my social media, it's a new mist or spray or cream or gel or pill or potion that's going to cure your menopause. And that's what's really scaring me is women are so desperate, so needy. They're just turning to anything to get help. And there's people preying on that.
Yeah. And what's your advice? I always say to people just on my little platform, like, follow a couple of different people and see how different they are. And I just say, find a doctor you like and trust, but not blindly. Like how do you sort of speak to that? Because in your professional experience, you know a lot of doctors and you know some are great and some are.
Right. So here's, every OBGYN is going to put menopause in their byline. When you go online and look at their website, what do you take care of? And menopause will be there. When you're looking on social media and you're trying to figure out, is this real or whatever, look at their credentials. Usually in their description of who they are at the top of their Instagram or Facebook or TikTok page, you will see if they're board certified, if they're an MD, if they're an ND, if they're whatever. Okay. So look to see if they're credentialed. Number two, look to see if they're selling something. Now, I sell things. So full disclosure, I sell a couple of supplements to, fiber and things that help women in menopause. But like, if they're selling you something in order to sell a product, that's a little bit of a red flag. When you're trying to schedule an appointment with a provider, call ahead. You're perfectly within your rights to call ahead, ask to speak to his MA, his nurse, talk to the front desk and be like, listen, does this doctor really do menopause care? Because not every woman is going to, and I'm just talking about hormone therapy. What I do in my clinic is much more holistic, but is this doctor willing to have a conversation with me about hormone replacement therapy? What percentage of his or her patients walk out the door with hormone therapy? If it's 100%, that's a red flag. Okay. If it's less than 25%, that's a red flag. So it's kind of an all or nothing, call ahead, educate yourself. On my website at galvestondiet.com, I have multiple blogs about what questions to ask, how to educate your own provider. Here are articles you can print out and hand to them to help them learn more and educate themselves on the safety, and the misrepresentation of the WHI study and what the North American Menopause Society is recommending now. So, go with your gut. If it feels icky, if it doesn't feel right, don't do it. Not every woman's going to choose hormone therapy or be a candidate for hormone therapy, but every single one of us deserves the conversation.
And if you had your dream of something to study, what would it be?
Oh my goodness. I'd love to see actual studies on testosterone. There's so many claims being made right now. We know that it's helpful for some, not for all, for hypoactive sexual desire disorder, what a layperson would call libido. But it's complicated. But there's claims being made left and right around brain function, brain fog, muscle strength. I would love to see focused studies on that. I would love to see studies on alternate forms of hormone replacement therapy. The only thing that was studied in the WHI was Premarin. I never prescribed that because I have an ethical problem with how they gather the horse's urine and that they torture the horses to do it. So I have other options for patients. Estradiol in and of itself has not been studied in large amounts. I'd be very wary about healthcare providers who go right to compounded options. They're very expensive. They're not monitored by the FDA. They're very often misused. I would ask, why aren't you prescribing something that's FDA approved? That is also identical to what my ovaries used to make. We have lots of options for that. That's covered by your insurance. You don't need to be spending carb payments every month to get good menopausal hormone therapy.
And do you have any take on the difference between progestin and progesterone as the offset?
So that's a great question. So progestins is kind of the umbrella term for every form of progesterone out there. Okay. Or progestins out there. Progesterone is kind of the end product of what is made in the pregnenolone pathway in our ovaries. Okay. So progesterone is the most active, biologically active progestin coming out of our ovaries. So when we talk about things being identical to what the ovaries made, it usually is progesterone. Now, for years, birth control pills have contained different types of progestins. So there's norethindrone, there's, Yasmin has drospirenone. There's probably, 10, 12 different progestins in different birth control pills. They're all synthetic. Those are all made in labs. And millions and millions and millions of women around the world take them safely every single year. So I don't like the demonization of, something synthetic versus something natural. In menopause care, I do tend to stick to things that are more like what the ovaries used to make. But, we are all biodiverse. Our bodies react differently. We cannot expect a group of 10, biologically diverse women to have the same reaction. And so that is why there are so many different progestin options on the market. In birth control pills, some are better for acne, some are better for hair loss, some are better for PMS, some are better for mood disturbances, as well as keeping you from getting pregnant if you don't want to be. And so in menopause care, there's just been this groundswell of demonization of synthetic versus plant-based and whatever, and there's just no studies to support those claims. Now, the progestin in Prempro is Provera, and that is the one that did show a very slight increase in breast cancer risk on women who took it. It went from about, and I hope I don't get this wrong, 3.2 to 3.8%. So 3.2 is the baseline in women 45 to 55, and it increased it to 3.8%. I stick to micronized progesterone just because of the Provera. It was in the study, and no one's looked at plain progestin. There was a study in France, actually. I'll take that. I'll walk that back. That looked at different progestins and the risks of breast cancer. And it turns out oral micronized progesterone had the lowest risk. So that is why I typically stick to prescribing that if a woman does well with it and tolerates it. So probably 90% of my patients end up on, who choose hormone therapy on oral micronized progesterone if they need it.
It's been described to me as like progestins have none of the benefits, but all the side effects of progesterone. Does that make any sense to you?
No, I've never heard that in my life.
Okay.
Oh, that's you did a little red flag. Are they trying to sell you something?
No, I like, it's more what I've noticed is it's the divide between the more mainstream and the integrative side. The integrative side is very progesterone focused. And
I am too, but not because I'm intuitive,
Right. You are like,
I like to, what I want to take for myself, what has the lowest risk. And I love that study out of France. And I want to do something close to what my body was used to getting.
Mm-hmm. And is it fair to say, when you look at the research and as a layperson, it just seems that a lot of studies don't separate them out still. Like they're still not they're sort of treating it as one category. So
right. So when you look at the black box warnings that come out for, the one for vaginal estrogen makes me want to pull my hair out and jump off a roof. That is based on the WHI. They never looked at vaginal estrogen. There's not a single study. The studies that have looked at the safety of vaginal estrogen, vaginal estradiol, it was zero increased risk of blood clots, zero increased risk of cancer. A woman with active breast cancer can safely use vaginal estrogen to treat her vaginal atrophy. The end. There's no increased risk. And so women are like this black box warning. The FDA needs to get their shit together. Excuse my language. In the US, I don't know what's going on in the UAE, but it's ridiculous. So yes, because of the WHI, anything with estrogen in it gets a black box warning. And same with progestins, because, progesterone being a progestin, because of the WHI study.
Okay. Now, so you talk a lot about the nutrition piece. You're a culinary nutrition specialist, and you have the Galveston diet book. When I was following you, it seemed like you and maybe this is what you were talking about earlier, it seemed like you pivoted more to be more about hormone therapy. And I just wondered if you felt that, like, it seemed like it almost seemed to me as you got more popular, but then also you're saying you kind of responded to what people wanted to know. So just sort of tell me how that happened.
So I didn't realize that women were being categorically denied by the millions, any option for hormone therapy, any.
Right.
I didn't know. And so that's where I felt like I have to take a stand here. And the more I dug into the studies being done, like the cardiologists looking at, women who were happen to be given hormone replacement therapy through early, starting in their late perimenopause, early menopause, within 5 years of their menopause, and continued for several years, had lower risk of cardiovascular disease and lower risk of death from heart attacks. Mm-hmm. And so I was like, what, looking at the orthopedic information coming out, there was, I think it was in Miami, it was in Florida, a study done between the Department of Orthopedics and the Department of ob-gyn, looking at frozen shoulder and the risks associated. And so seeing that, oh my God, frozen shoulder has a direct correlation to menopause, and, other musculoskeletal complaints, other arthritic conditions, other, capsulitis is what frozen shoulder is. So, I mean, I was like, wait a minute. And so I would just see all these things and just start talking about it. And a million women would respond and go, oh my God, that was me. That happened to me. And so, yes, I'm very pro hormone therapy, only because women haven't heard this. They didn't realize that they could possibly take it. And I just felt like you need to know that a doctor who's unwilling to discuss this with you is not a menopause provider, and you deserve better. Mm-hmm. And so, when I talk about, I started with nutrition. So when a patient comes to my clinic, to Mary Claire Wellness, I call it the menopause toolkit of their care. And we come up with a plan. And so in that toolkit, it looks like a caboodle when we were kids, the little makeup holders that look like a tackle box. It was basically a pink tackle box. And the biggest compartment in that box, the most important thing, is going to be nutrition. Absolutely. The next biggest, the next thing just about as big is exercise, movement. Okay. The next thing is going to be possible pharmacology, which may be hormonal or not, depending on her risks, her symptoms, her, whatever. I have lots of patients who were treating hot flashes non-hormonally with other pharmacology. We talk about possible supplementation. Are there gaps in her nutrition? Are there things that other, turmeric or things that might be helpful? Extra magnesium, even if she's not, magnesium can be therapeutic for sleep, for anxiety, for depression. We talk about stress reduction. What does that look like to you? Is that a walk? Is that praying? Is that going out with friends? Is that journaling? Is that meditation? Carving time out for yourself to lower those cortisol levels, and then getting adequate sleep. All of those things are so important to keep you as healthy as possible for as long as possible. So I'm not an HRT, one and done, get out, go ahead, you're going to have a wonderful life. I'm like, you need to be realistic here. It can do a lot of things for you, but we have to do the work. We have to change our habits if you want to be as healthy as possible for most of us.
And when you're prescribing hormone therapy, what's your approach? How do you approach that?
So first of all, we need to decide, are they postmenopausal or perimenopausal or premenopausal? And usually that's done clinically. You just have to talk to the patient. You don't need an extensive blood work panel. You don't need all this stuff. Literally, if you know what you're doing, you can talk to the patient, believe what she's telling you, and then make the clinical diagnosis. And so then we start launching into what hormones may or may not do to aid her during this process. It's a very different conversation if she's premenopausal, different if she's peri, and then different if she's post. And so we kind of gauge that discussion. And then we talk about options. How do we get these hormones into your body? Okay, we have oral, we have non-oral. That's the two main categories. What can oral do? What can non-oral do? Why I tend to go with non-oral, transdermal, because when we ingest estrogen in any form, anything we go put in our mouths and into our gut gets absorbed through the intestines into the portal vein, which goes to the liver for processing. That is how we were developed as mammals. Well, the liver, when it gets that bump of estrogen, it's called the first pass effect, can upregulate some of our clotting factors with estrogen. And we can see about 7 out of 10,000 women will have a blood clot who would have not otherwise. And so for that reason, it's a very small risk, but I can negate that risk by using a transdermal form. So most of my patients end up on a transdermal form of estrogen if they want to go with estrogen.
Okay. There was recently in the UK, the Daily Mail did an article and 6 guiding bodies followed up about concerns over private clinics over prescribing, like double estrogen doses, not enough progesterone, some discussions that women had become ill. And I just wanted to know sort of, It seems to me that, they always say low and slow for cannabis. Like, it seems to me like low and slow is not a crazy bad idea when it comes to hormone
Right.
therapy. What do you
So
think?
a lot of clinics and clinicians are getting a hold of these protocols, which are giving you these arbitrary dosage. They're basically a therapeutic range. And let me tell you loud and clear to your followers, there is no therapeutic range that has ever been studied and documented as the number you want to hit to be adequately treated for your menopause. We do not have blood level ranges. We do not have urinary test ranges. And so women are spending thousands of dollars for unnecessary testing to go through these protocols. And quite often they are being over treated. I treat based on symptoms. It depends on how old they are. It's an art at this point, talk to the patient. How bad are her symptoms? How young is she? I start a little higher if they're younger, a little lower. And then I basically say, listen, you need to tell me how you're feeling. How are you sleeping? How are your symptoms? If they're having side effects, we'll back down on the dose. But these doses were studied by the FDA. We know we're not going to get anyone toxic with the FDA approved dosages. I have seen people come in with estrogen levels in the high hundreds. I have seen people come in with testosterone levels in the hundreds. And they've got acne, they've got chin hair, they're losing hair on their head, and I'm like, why were you given this? Did you have any issues with sexual desire? No, my estrogen was low and they needed to replace it. We don't have enough studies to support. I have not seen enough studies to support the routine replacement of testosterone. Now, if that changes in the future, I will be the first one to recommend it. But for now, unless she's suffering from hypoactive sexual desire disorder in the absence of other causes, such as pain, such as a relationship disorder, such as an orgasmic disorder, those are the women, those are the patients that I am prescribing testosterone to.
And are you testing those people because you have an indication? You think, I got to look and see what's going on here. It seems like they would have.
If she's postmenopausal, her
Mhm.
testosterone's low, it's made in the ovary and the ovary's not working anymore. I don't need to test that. I mean, I will make sure they don't have a tumor,
Yeah.
And so if they're showing signs of high levels of testosterone, I will check a level to make sure, she's not having an ectopic production somewhere. But, routinely checking testosterone in a woman who has no complaints, I don't have enough indication to treat that yet outside of libido.
This is rampant though on social media. Like, I see women constantly saying, I had my levels checked and they were this and they were that. And it's like, to me, it also seems like, when you don't want to admit that you're in perimenopause. I didn't even know about perimenopause till I was 47. So, and I say there's got to be some denial in there because I was a health and wellness journalist. Like, I obviously I knew, but I don't think I knew about, we talk about that a lot. But I feel like sometimes there's a level of denial because people will go get their hormones tested. People will test them and then they'll say, no, my levels are perfect. And it's like,
So
yeah, but you're not, you're having problems sleeping. You're having some anxiety, right? Like,
and that's a fallacy of how we're educating. There's zero education in traditional ob-gyn programs and family medicine, anybody who does women's healthcare around perimenopause. Like, I've had doctors tell patients have come back to me and said, I was told they don't believe in perimenopause, like it's the tooth fairy. And so when we are great blood work wise about diagnosing postmenopause, your estradiol levels plummet, your follicular stimulating or FSH levels skyrocket. Okay. In perimenopause, I'm like doing the graph. So we have a graph of what, if we normalize the estrogen levels through the 7-10 years of perimenopause, you'd see a downward slope. However, in actuality, it is doing this on the way down. And it's a very complicated feedback between the hypothalamus, pituitary, and the ovary. And the ovaries, basically, we're losing our eggs. We're born with all of our eggs, right? Like a million or so.
Mhm.
And then they slowly deteriorate. We start, trying to ovulate them and we lose the function. And we start getting fibrosis and, they're just, and their quality of the eggs. That's why risk of chromosomal abnormalities goes up with the age of the eggs, so they just become dysfunctional. And the hypothalamus pituitary are like, hey, we need more estrogen. And they're just surging so hard. So, and then the ovaries will be like, and spit an egg out and estrogen levels will normalize for a little bit and then it'll plummet again. And so you just go through this jalopy, this car just pop, sputtering on the way down. So one-time blood test in the middle of this zoo is not going to be diagnostic and quite often looks normal. So it's not appropriate to use an FSH or estradiol to diagnose perimenopause. It is a clinical diagnosis. Listen to the patients. I'm not sleeping. I'm having hot flashes. I'm irregular. Yes, I'm having periods. Who gives a shit about that? Like, you can still have completely monthly cycles and be perimenopausal. I just want to reassure patients, and it takes a clinician willing to untangle. Now, do I do other blood work? Of course. Hypothyroidism often presents very similarly to perimenopause. Autoimmune disease, there's multiple other conditions, vitamin deficiencies, anemia. And so I'm checking for all of those. 99%, I'm checking all of those things before I'm going to check a hormone level.
Okay. I was going to ask you about autoimmune because I recently have found out I have hypothyroidism, and it does feel different, but similar. Like what is your take on hormone therapy if people aren't checking for those? Because the thing I worry about is in the background, these autoimmune conditions are going on, and maybe people
and they're accelerating in perimenopause. When the estrogen levels drop, inflammation goes up, autoimmune disease goes up. So what I've seen now, I don't have any studies for this, and I could probably find some, but women are being overtreated for clinical hypothyroidism when their labs look normal because it's really perimenopause, and the doc doesn't understand perimenopause. So like, it must be your thyroid. Nothing else makes sense. So these women are coming in basically hyperthyroid, they're iatrogenically hyperthyroid because they're being treated with Armour thyroid or something for something that the healthcare provider was at their wits' end trying to help the patient, didn't understand perimenopause, didn't know how to support someone through a perimenopause journey hormonally, and was really just trying to help. And so they're like, well, I'm going to treat the patient, not the symptoms. And we get so addicted to like blood tests and lab tests. I'm like, listen, use your brain, use your diagnostic capability, listen to her, believe her. Stop dismissing these symptoms. This is perimenopause.
But then you did say that we're more vulnerable during this time. So can you just talk a little bit about that? We're more vulnerable to a lot of things, but autoimmune also.
So every single organ system of your body, from your brain to your bones, to your skin, to your joints, your vagina, your uterus, your endocrine system, your cholesterol, your liver, all of it has estrogen receptors, and it was plugging along doing great. Okay. Mm-hmm. As you were, our normal, and there's no balancing hormones, by the way. We need to stop using that term. Our hormones are not balanced. They're only balanced when you're prepubertal, our sex hormones, when you're prepubertal and when you're postmenopausal, because they are right. They're flatlined. Okay. And so in a normal, healthy reproductive cycle, it looks like an EKG each month. Estrogen, progesterone, FSH, LH, they're rolling. Okay. And then when we get to perimenopause, they're skipping, and so when those organ systems are affected by these changing sex hormone levels, everything is affected. Everything. And so when you look at a disease process that we know happens in women, happens in their 40s to 50s, and is not happening to men at the same rate, you better bet your bottom dollar and do some investigation that this may have a sex hormone component having to do with her perimenopause and menopause.
Okay. And what about all the people who are having gut problems? How does that play out?
So I've read some beautiful studies looking at the gut microbiome. And if you're not paying attention to your gut microbiome, you should be. Okay. People poo-pooed it. I poo-pooed it. I didn't understand nutrition and how the gut microbiome works. But when they specifically looked at stool samples through premenopause, perimenopause, and postmenopause and compared them to a man's at the same age. So a man's gut microbiome stays fairly stable throughout his life. Okay. Depending on, unless he moves to a new country and eats different food and whatever. Our gut microbiome is very, very protective of our cardiovascular system and of our gut in general. Okay. The oxybutirates that are performed, the type of bacteria that are in the gut. When we lose our estrogen levels, our gut microbiome shifts to that more like what a man has. And with that, our cardiovascular disease risk, our dementia risk, our Alzheimer's risk begins to climb, and heart disease approaches that of a man's.
Okay. And do you think you should go on hormone therapy if you're managing your symptoms, or if you're not really having anything crazy?
Yes. Okay. If you have no contraindications, I do. I wouldn't have said that 10 years ago, I was only treating the symptoms of menopause, but after everything I've read, talking to multiple doctors in other specialties and looking at the quality of life, the health outcomes, the bone strength, the genital urinary issues, the quality of life, absolutely. I think a woman, for her, from an evolutionary standpoint, we are reproductive creatures. We are meant to reproduce. Okay. And once our ability to reproduce goes away, then we die. Okay. That is so we can make room for the next generation. That is what we were born and programmed to do. Medicine is here to improve the quality of our life. So no, you don't have to take hormones, and your body, your choice. I support that. Right. Okay. But you're putting yourself at higher risk for other disease processes. That is something you have to understand. And so you're putting yourself at a higher risk for cardiovascular disease, but you have to start young. That's the thing. You can't once these disease processes get started, unfortunately, estrogen can make it worse. It's the healthy cell theory. So the best thing you can do is never have a gap in your body's estrogen. Once your body starts declining estrogen production, supplementing that is going to go a long way for your overall health.
And is this a recent thing? Because women have lived to old age, like since time began. We have lots of old women in our history, and they didn't take hormone therapy because it has only been around since the 30s. So how do you reconcile that? Is that sort of like an evolutionary pressure that's developed, or what do you think?
I think what's happening in our environment, our diets have changed, our exercise habits have changed, our stress levels have changed. And so our quality of life is not improving. My patients come to me and they are looking at their mothers, their grandmothers, more their mothers. Their grandmothers actually did pretty well. But it's like watching their parents being plagued by chronic disease processes. And they're like, I don't want that.
Mm-hmm.
I don't want my children to be as freaked out and worried about me for so long. I mean, everyone's parents are going to die. We're all going to die. But like this long, protracted time period of people not being able to care for themselves, requiring intervention, having a very poor quality of life. I mean, it's devastating for a child to watch their parents go through this. And, they don't want that. And I'm like, okay, here are things that we can do for nutrition, exercise. What are the studies saying? Hormones, other pharmacology, the menopause toolkit, so that you can have a better quality of life as you go through this.
Okay. What about the spiritual side? Like, it just seems like there's a lot of people really struggling. And I wonder, you go through so much. There are some studies that look at like adverse childhood experiences and trauma being processed, socioeconomic factors, stress. Like, there is stuff by the time you hit midlife that you need to process and deal with and reckon. I think I'm in my last year. I'm calling it my second meno trimester.
Oh, that's a great way to put it.
Well, I never had kids, so I never had any trimesters. So
I read a fascinating study about a history of sexual abuse and trauma. You're much more likely to have more severe symptoms of menopause.
Right.
And if you're a super flasher, meaning you have complete life disruption from your hot flashes, your risk of cardiovascular disease is much higher. Now, how do we untangle that? How do we untangle that? It's all related. And so I think that, my daughter had a traumatic event happen her senior year of high school, horribly traumatic. And she immediately got therapy and has been in therapy just for life, and she just was like, everyone should do this. And so I was struggling with some things recently having to do with her trauma. And she was like, Mom, just go online and find, and it was such a wonderful thing that I just, there's not, mental health is something we take for granted, that we have to muscle through it, that we, and my menopause had really rocked my world and all my coping skills kind of went away. And so letting someone help me process these emotions was life-changing for me. And I had to thank my daughter. At least this next generation is way more open, and the stigma around mental health and what they need to do to stay healthy in their minds is huge.
Yeah, we have a lot more to unpack. When you were born in the 70s, it was a much different era. Okay, last question. What's your top question to someone who's just like, I can't even right now. Everything's wrong.
I hear you. Let's talk about it. What's going on? When's the last time you felt okay?
Mhm.
And what was that like? And walk me through this journey to what got you to where you are today. And let me help you unpack this and untangle this, at least medically. And so it'll help me guide what blood work we need to get, what I'm gonna need to make sure I'm not missing before we kind of address the menopause picture.
So if they can't see you, find someone who will do that. And I'll say keep going and keep trying to find someone because
Right. Don't give up. There are people out there. There's some great online resources in the US that are doing, I think in person is always best. But if you cannot find anyone in your area, there's some online new companies that have come up. I really like Alloy Health. I like MIDI Health. There's a new one called Evernow. And I've read their protocols. I've talked to their medical directors. I'm not affiliated with them at all, but I feel like, everybody deserves a conversation. If you can't find anybody in your area, one of these companies might be helpful for you.
and people always talk about money, but I mean, if you don't feel well, it doesn't matter. Like nothing else is worth buying. I feel
Right.
like.
Nothing, if you're not healthy, doesn't matter how much money you have, you
Yeah.
can't buy anything like, so yeah.
Shoes don't matter. So, and whatever, I've had to save up myself to see someone, but it's like, it's worth it. It's very expensive here and the doctors are. So last question, you're writing a book about menopause.
I am. So, people were begging me to do it. And so I really thought, and I have multiple questionnaires out to my followers, like, what do you want to see in a menopause book? That's not existing right now. And so the book is basically going to be something you could hand to your 35-year-old self, hand to your 35-year-old daughter, your friend, your coworker, whatever, so that she is prepared and ready and she knows what could possibly happen, what her treatment options are, everything from what we know about nutrition, what exercise, what pharmacology, what hormone therapy, can be helpful for her to help her be as healthy as possible through this part of her life, which is inevitable. I mean, Oprah said it best, though you had to pay $35 to watch it. You can't outrun, out earn, outfox, menopause is coming for you. If you live long enough, this is happening to you and it is going to change your life.
Okay.
But you don't have to suffer and you can actually really, really thrive during this time period and live your best life. But, and if you need help, we're here for you.
Okay. Well, listen, thank you so much. I really appreciate it.
Sure.
Abu Dhabi to Texas.
Yeah.
It's amazing what you can do now. Well,
Yeah.
good luck with everything and I'll be in touch when I run it.
Thank you.
Thanks.
Okay. Take care.
Bye.